or if it's for your blood pressure or whatever. All right. You take it in a variety of ways. Okay. The drug can be topical, which means it goes on your skin. Okay. It could be sublingual, which means it goes under your tongue. All right. It could be a patch, which means it absorbs into your skin. All of those routes, or it could be injected. Okay. All those routes are what are called parenteral. Okay. Parenteral. Let's write that down. And what that means is just a term that means it avoids the digestive system. And the reason you want to do that sometimes is because the drug wouldn't be able to handle the environment of the digestive system effectively and deliver its impact. Okay. So for instance, once it would hit, say, the acid in the stomach, the drug would be destroyed. It would no longer be effective. So you have to have another way of getting it in there. All right. Now, with injected drugs, right, we need to be aware of different ways you can inject. Right? So these are the parenteral ways of doing it, right? Parenteral. I'm only writing on just the title slide. Okay, so parenteral. Okay. Means not through GI. Okay. So that's inject, patch, topical, sublingual. Okay. All those ways to get in. Now, when we talk about inject, okay, different ways to inject, right? There's IM. Okay. There's subcutaneous. There's IV. Okay. And there's IP. All right. So what is IM? IM is intramuscular. Okay, which means directly into muscle tissue. And then you let it be absorbed. A lot of drugs that are non-polar are injected intramuscular, right? And then they absorb slowly into the blood vessels. Subcutaneous, all right, means into the hypodermal layer. Okay, where there's lots of blood vessels. IV means intravenous. Okay, and IP means intraperitoneal. Okay, peritoneal. All right, so the first three are used on humans. The last one is generally used on animals. IV, intravenous, into a vein, right? IP into the peritoneum. So you actually go through the abdomen and you inject the drug into the peritoneal cavity, and then the blood vessels in the peritoneum pick it up, right? You do this in animals when you do things like animal testing, like in mice, okay? But those are the different ways to inject, okay? Now, enteral, all right, means through the GI. Okay. And that can be a pill or liquid. Okay. Either one. And it'll survive the acid of the stomach and be able to exert its effects as it moves across the lining of the GI and into the blood. All right. So different drugs have different chemical compositions, and this is why we have to give them in different ways. Okay. Um, so we're going to talk about pharmacology and how we do this. All right. With few exceptions. Okay. Antibiotics, it can't and don't add any new physiological, biochemical, or biological functions to living tissue. They change the rates at which responses occur. Okay. Pharmacodynamics is going to address the drug-induced response of the physiological and biochemical systems of the body, while pharmacokinetics talks about the drug amounts at various sites in the body after administration. In other words, you give it, how long does it stay there, and how long does it take to distribute, if it's going to distribute. Okay. Branches of pharmacology include pharmacotherapeutics, where we have issues associated with the choice and application of drugs; toxicology, which is the study of the body's response to poison; and pharmacy, which is the prep, compounding, dispensing, and record keeping of therapeutics, right? In toxicology, responses include harmful effects, mechanisms of action, symptoms, treatment, and ID. Pharmacy can also be split into pharmacognosy, which is the mechanical and other sources of the drug, right? We get drugs from a lot of places, right? Sometimes we just whip them up in the lab. Other times we get them from natural products. Sometimes we get them from natural products, study them, and then modify them. Pharmaceutical chemistry, which is the chemical synthesis and modification of new and existing drugs; and biopharmaceutics, which is the effect of formulation of drugs on the pharmacodynamic and pharmacokinetic properties. Okay. So when we talk about drug nomenclature, we're talking about the over-the-counter name versus the IUPAC name. The IUPAC name is just the name given by the American Chemical Society. Okay. Yes, you all. That's right. Okay. Drugs are over the counters. They're approved by the FDA. Herbal supplements are not. Okay. Prescription drugs are required by law to be prescribed by licensed practitioners, such as a doctor or an osteopath. Okay. Because all drugs are potentially poisonous, understanding the nomenclature is critical. It's also practical because it specifically identifies the correct drug for the correct use. This starts with their manufacture in the pharmaceutical industry, continues to distribution at the pharmacy where the drugs are dispensed, and then ends with medical personnel who give them to the patient, or sometimes the patient gives it to themselves, right? They can be administered by medical personnel, or they can be administered by the patient. Drug nomenclature is needed for precise chemical description that can help to avoid medical disaster. Okay. Individual drugs always have three names: the chemical name, which is the accurate chemical description. That's what's called the IUPAC name. Okay. The generic name, which is a non-brand name. Okay. Antimicrobials, anticonvulsants, analgesics, right? Generic name for an antimicrobial would be something like penicillin, anticonvulsant, dilantin, okay, and so on. And then the trade name, okay, which is assigned by the company that makes the drug. If a drug is made by a lot of different manufacturers, the list of proprietary names can be lengthy. As an example, Procaine has at least 24 different trade names, okay, all given by the different drug companies that produce them, okay. So you can see some examples here, right? Trade name, right? For amoxicillin, right? Trimox, Dispermox, there's more, okay? The chemical name is listed there to the right, okay? 2S, 5R, 6R, 6R, minus 2 amino 2 parahydroxyphenyl, acetomidol, 3,3-dimethyl 7-oxo 4-thia 1-azabicyclo 3,2 heptane 2 carboxylic acid trihydrate. Okay. the therapeutic class is antibiotic. Now, you can see these IUPAC names get long. Okay, these are names that are given by the American Chemical Society, right? These names are the kind of things you would run into in a course in organic chemistry. Okay, or a full-blown course in pharmacology, right? You just know that, right? Are we going to make you spit out IUPAC names? No. Okay. We probably want you to know the generic and maybe some trade names. That would be in the class. Okay. But all of these, they're all the same thing. Okay. This is one of the reasons why when you buy a generic drug, they're usually less expensive.
7 minutes.
Less expensive than a marketed drug. Okay. Because when you buy a generic drug, you're paying for the marketing. Okay. That's something you need to be aware of. So always, if you can, ask for the generic, right? Because that's going to save you some money. All right. Sources of drug information. Well, there's quite a few, right? There's your clinician, your doctor, your pharmacist. There's poison control center. There's your sales rep at the pharmacy. Okay. And of course, there's the internet for other sources of information, right? Textbooks, reference books as well. Okay. Get information about it. Drugs change physiological activity and they have to reach their target in appropriate concentration in order to do their thing. Okay. It involves drug administration. You take the drug. Absorption, it gets in you. Biotransformation, it gets metabolized. Okay. Meaning enzymes work on it and change it. Okay. It gets distributed, all right, meaning it gets sent out to the eventually the target, right? And then it gets cleared. Okay. So this is a very important point, right? Clearance is always going to involve your liver and your kidneys more often than not. Okay. The liver is going to turn the drug into a water soluble form. Okay. And the kidneys are going to excrete that form. Right. It has to be water soluble to get it to the kidneys in the first place. Right. Otherwise, they're not going to be able to clear it at all. The point being that every drug you take puts a load on the liver. And it's one of the reasons why if you abuse your liver early in life through excessive alcohol consumption or drug consumption, you're going to end up costing yourself possible therapeutic routes when you're older. Right. In other words, if you're an alcoholic, let's say, and then you stop drinking, you're going to still have liver damage there. And if you need an antibiotic later in life, we might not be able to give it to you because your liver won't be able to process it properly. Okay. So that's a price you pay for recreational drugs and alcohol that you don't realize when you're doing it. Okay. Is that if you need a life-saving drug later on, you might not be able to take it. Okay. So it's just something to be aware of. Right. Physiological activity of the drug, if it's enteral, right through GI, you have drug loss from breakdown in the stomach, from what's called first pass effect. We'll learn about that in a minute. From the small intestine, from failure to be absorbed, binding to food and other material, breakdown in the liver, secretion in the bile, biotransformation, and tissue binding. Okay. With both enteral and parenteral routes in the blood, you have biotransformation. binding to plasma proteins. In distribution, the drug can be too dispersed or insufficient at the site of action. It may not bind the tissue. It may be biotransformed into something that's inactive or maybe even toxic. It can be metabolized so that it's not the form that you want acting at the target, and then it can be excreted, right? So when we talk about drug administration, we've sort of addressed this already, right? It can be on the skin. On the skin, it's called topical. Okay. It could be on mucous membranes. Where are those found? Well, respiratory, GI, urinary, and reproductive. Okay. They can be oral. Okay. So those are limited to osmotic cathartics, osmotic diuretics, and antacids. Okay. And it can be inhaled for respiratory and lung diseases. And it could be ionophoretically enter through the skin through control of charge. Okay. So drugs administered entirely through the GI or parenterally through a system other than GI are given to affect only the site of administration or systemic.
Medication absorption is the movement of a drug from its site of administration into the blood. Oral drugs enter the stomach, where they either dissolve and pass through the cell membranes of epithelial cells lining the stomach, or travel undissolved through the stomach to the small intestine, which is the most common site of absorption. Here, drugs dissolve and pass through the intestinal wall. Oral drugs then travel through the portal venous system to the liver, where they undergo the first pass effect. During this process, the liver metabolizes some of the drug, either inactivating it or excreting it into bile for elimination from the body. The remaining amount of active drug leaves the liver and reaches general circulation and target organs. If a drug is administered via intravenous injection, it passes directly into the bloodstream, thus bypassing absorption in the GI tract. If administered through intramuscular or subcutaneous injection, the drug enters either muscle or subcutaneous tissue, where it passes through gaps between cells into capillary walls, and then into general circulation or target organs, also bypassing absorption in the GI tract. Bioavailability is the net amount of a dose of a drug that is actually absorbed into the bloodstream. The bioavailability of oral drugs is less than 100% because of the first pass effect of the liver. In contrast, the bioavailability of IV drugs is 100% because they are not exposed to the first pass effect of the liver. Different drug formulations alter bioavailability because they are not absorbed at the same rate or to the same extent. For example, tablets dissolve at varying rates. Enteric-coated drugs dissolve in the small intestine, not the stomach. Because gastric emptying time differs between individuals, absorption times also vary. Sustained release formulas contain tiny spheres that dissolve at different rates, resulting in a steady drug release throughout the day, but also resulting in variable absorption. Some factors affecting drug absorption are the rate of dissolution. Drugs that dissolve faster are absorbed faster. Surface area. Since the lining of the small intestine has more surface area than the lining of the stomach, most drugs are absorbed faster in the small intestine. Blood flow. The greater the concentration gradient between the drug-filled stomach and the rapidly flowing drug-free blood, the faster the absorption. Lipid solubility. Highly lipid soluble drugs pass through the phospholipids in the cell membrane more easily than drugs of low lipid solubility. And pH partitioning. Absorption is faster when the difference between the pH at the site of administration and the pH of the plasma attracts more drug molecules to ionize in the plasma.
So when we look at local drug administration, right, we can go through the skin, we can go through the GI, we can be inhaled, or we can go through mucous membranes, such as in the eyes, nose, mouth, and your genital tract, okay, or ionophoretically, right, through the skin. Systemic effects. Transdermal therapeutic systems are the delivery of a drug controlled slow release drug reservoir attached to the skin, okay, such as a patch. Okay. Sublingually means under the tongue. Example would be nitroglycerin tablets. There's a lot of blood vessels under the tongue that can absorb the drug. Orally, right, by mouth for absorption through the GI. That's probably how you're familiar with taking most drugs. Okay. Rectally by suppositories in the rectum, in the anus, into areas of extensive vascularization and rapid blood flow. It's useful in infants and patients that are unconscious. All right. And of course, it avoids the action of the GI. Inhalants, which go into the lungs, which is another area of extensive vascularization and rapid blood flow. Okay. Subcutaneously, below the cutaneous layer, it's good for slow absorption of small amounts of drug. IM, rapid rate of absorption because of extensive vascularization and rapid blood flow, but less than by IV, which is directly into a blood vessel, right? It can be through a modified port, such as a cannula in the great cable veins, or repeated drug administration, as in a cancer chemotherapy patient, or by IV bolus, a large volume of fluid given intravenously and rapidly at one time for an immediate effect, or it could be injected. Okay. Intrathecally is administration into the spinal subarachnoid space. It's less invasive than some other methods and allows distribution into a larger area through circulation of CSF. Remember, the CSF is made in the ventricles of the brain and circulates through the core of the brain and the middle of the spinal cord by filling those ventricles and the central canal, but also fills the entire subarachnoid space and then rejoins the blood supply at the dural venous sinus between the two cerebral hemispheres. Okay. Absorption describes the rate at which a drug leaves the site of administration and the extent to which it appears at the site of action. The term is used to indicate the extent to which a drug reaches its site of action. This is known as bioavailability. Right? The three general sites of action are extracellular, which includes sites such as a decrease in blood clotting by heparin's chemical combination with proteins to remove them from the coagulation cascade, okay, or cellular, such as the contraction of skeletal muscle by the action of acetylcholine at the nicotinic cholinergic skeletal muscle neuromuscular receptors, or intracellular inside the cell, such as inhibition by sulfa drugs of bacterial growth through the inhibition of intracellular components needed for bacterial growth, such as, say, affecting protein synthesis at the ribosomes. Okay. So, extracellular, outside the cell in ECM, right? Cellular, at the cell surface. Okay. Intracellular, inside the cell. Okay. The rate of drug absorption is influenced by the anatomic and physiological properties of the site of administration and the physical and chemical properties of the drug. Okay. Um, the factors include surface area, which is the amount of surface area um, is going to have a direct effect on the rate of absorption. The larger the surface area, the faster the rate. Okay. The rate of dissolution, which is the rate at which the dissolved drug will determine the rate of absorption. The faster it dissolves, the faster it's absorbed. Okay. Drugs with high dissolution rates have a faster onset of action than those with a low dissolution rate. Lipid solubility, right? Drugs that are highly lipid soluble can more easily cross biological membranes than those with low lipid solubility. In fact, when we talk about lipid solubility, we should address something very important here, okay, which is toxicity. So let's back up to address that for a minute. Okay. Okay. Now, a water soluble drug can always be cleared by the liver and the kidneys working together. All right. But a lipid soluble drug has to be processed by the liver in order for it to be water soluble and be excreted by the kidneys. But what can sometimes happen is that if you take high doses of a lipid soluble compound, it can simply reside in our fat stores and in fatty substances like the myelin in our nervous system. Okay. And it can live there indefinitely in some cases. Right. So this is one of the reasons why, for instance, the fat soluble vitamins A, D, E, and K. Right? If you take too many of them, you can get up to toxic levels, and over time, that can have negative effects on the body. In addition, we should point out that lipid soluble compounds basically have no barriers as to where they can go. Okay, because they can cross barriers, because they can cross the membrane very easily. They can go, say, across the lining of the gut into the blood, and from the blood directly into the central nervous system, right? Where they can either be stored for long periods of time, or um, they can exert a negative effect. Okay. So some stories about this, right? Some are kind of scary. Right? But if we go back to uh, 1800s, okay, there were a couple of jobs there that interacted with lipid soluble drugs. One was haberdashery, haberdashery, uh, the chimney sweep. The chimney sweeps had a terrible job. They had to go down into the chimney and clear out the coal dust so that the smoke wouldn't fill the building and kill all the people inside, right? Smoke inhalation. The coal dust contained a compound called DES, diethylstilbestrone, which is a potent carcinogen. So over time, this carcinogen accumulated in the fat stores in the body, and a lot of these chimney sweeps died of testicular cancer. Okay. The haberdasher story is even more interesting, right? If you've ever read Alice in Wonderland, okay, there's a character in there called the Mad Hatter. Okay, and he's crazy. Well, this is based on an actual thing, right? The haberdashers would try on the hats to size them, right? And the hat bands were treated with elemental mercury, okay, which is a lipid soluble metal, heavy metal. And when it's processed by the body, it becomes a neurotoxin. And so, what would happen with these high doses of mercury over time is they would lose cognitive function. It's the Mad Hatter. Fast forward to the 60s. Okay. There's a drug called LSD. Okay. It's a product of a fungus called ergot. It's a lipid-soluble hallucinogen. It's popularized by Timothy Leary as a mind-expanding drug. Well, what would happen with people that dropped acid in the 60s is that it would accumulate in the myelin in their brain. And long after they quit taking it, they would have flashbacks because occasionally the drug would reemerge from the myelin and re-exert its effects. Okay. So they never really totally cleared it. All right. Another example is lead. Tetraethyl lead was an additive in gasoline and also paint. Okay. Tetraethyl lead is a neurotoxin, right? So people get high doses of tetraethyl lead can end up with cognitive deficit. Well, a lot of kids like to eat the lead paint chips because they tasted sweet, and it would affect their IQ scores. Right? So we took the lead out of the paint. The lead in the gas is the same thing. Right? The tetraethyl lead in the gas was there to stabilize the mixture, but of course it got into the environment and had its negative effects on the organisms that consumed it. Right? Just like the lead paint had the negative effect on the kids. Okay? So we took the lead out of the paint. Right? The hazards of lipid soluble compounds are something you need to be aware of, which is why if you get exposed to them, right, you have to be monitored for them building up to toxic levels. Right? So that's my little spiel on lipid soluble compounds. Another example of a lipid soluble compound is an anabolic steroid. Right? These are generally taken as PEDs by athletes, okay, performance enhancing drugs. Okay. And what it does is it sends the body into overdrive with biosynthesis so that they can exercise more frequently and build more muscle mass more quickly. All right, which is great. Right, so you get bigger, stronger, faster. The problem is because it's lipid soluble, it can go into the brain. Okay, and can affect brain function. Okay, and so you probably heard the term void rage. And that's an example of a toxic effect of anabolic steroids. Okay? You have to be careful with these things. Okay? Right. Blood flow, right? That's the last bullet point, right? Drug absorption in areas of high blood flow is greater than in areas with decreased blood flow. And of course, that makes sense. Okay? The transfer of drugs across biological membranes into body compartments, such as combined intracellular and extracellular fluid compartments, is part of drug distribution. Depending on the drug's chemical properties, solubility, blood flow, molecular size, and excretion, right? Water-soluble drugs are readily excreted for the reasons we already said, right? They're already able to be dissolved into blood, and that means the kidneys can clear them easily, right? The blood-brain barrier is an obstacle, okay? And the placenta can be a pathway for transfer as well, right, into the baby. Now, the blood-brain barrier, remember, okay, is established by astrocytes and ependymal cells. Okay. And the idea here is to keep harmful water-soluble material away from the central nervous system, because the central nervous system, even though it's well protected by bone and membrane, CSF, right? If something gets through that, then the CNS is pretty defenseless. It only has the microglia to try and fight off whatever is in the blood that's a pathogen. Okay. So the blood-brain barrier, it provides that extra protection by sealing the endothelial clefts in the blood vessels that are found on the surface of the CNS. Okay, and by allowing the appendable cells to make a fluid that is approved for neural function, the cerebrospinal fluid. All right. So with a drug, a water soluble drug, it's an obstacle. Okay, lipid soluble drug, remember, can go wherever it wants. Right. So let's take a look at drug distribution.
Distribution is the process by which a medication is carried to its target tissue or site of action with the goal of causing a therapeutic response. This process follows medication absorption and precedes medication metabolism. Medication is first carried to highly vascularized tissues, including the liver, heart, kidneys, and brain. Then, medication is widely circulated within the body, reaching areas of less extensive blood supply, such as skin, muscle, and fat. Medication then accumulates in the fat and in poorly vascularized tissues like bone, especially if the medication is lipophilic or strongly attracted to lipids. In the blood, some medication molecules bind to plasma proteins to which they are attracted. In this bound state, medication molecules are unable to produce a pharmacological effect. In bound and unbound form, the medication flows through the arteries and into capillaries. Capillaries carry the medication close to the tissue's cells, where hydrostatic pressure drives molecules between the capillary endothelial cells into the interstitial space. Some protein-bound macromolecules are too large to pass through the vessel walls, so they never reach the target tissue. Unbound or free molecules do reach the target tissue by exiting the bloodstream between the loose junctions in the capillary endothelium into the interstitial space to interact with the tissue cells. Some molecules bind to the cells, while others remain in the extracellular fluid. The interaction of the unbound medication with the target tissue results in a therapeutic response. There are many factors that affect distribution. For example, the effect of membrane permeability on distribution can be demonstrated in the brain. The brain's capillaries are impermeable to the majority of medications due to the blood-brain barrier, a membrane that blocks the entrance of both toxic and therapeutic substances into brain tissues. Some medications penetrate the blood-brain barrier based on features like low polarity and high solubility in lipids. Fat-soluble molecules cross cell membranes faster than water-soluble molecules due to the lipophilic nature and phospholipid composition of the cellular membrane. Factors such as body fat percentage and disease also affect medication distribution. Fat deposits retain lipid-soluble, unionized medication and release the molecules over time. Thus, obese patients may experience prolonged pharmacologic effects. Inflammation, disease, and injuries such as burns can alter protein levels and thus medication binding, increasing capillary permeability and uptake in cells and tissues. As a complication of kidney disease, albumin cannot bind medications effectively, resulting in a low percentage of protein-bound medication. These shifts result in high levels of free medication circulating throughout the body.
Okay, let's take a break. In this case, is a mechanism by which the body inactivates drugs and engages in phase 1 and phase 2 reactions. The liver plays a major role in drug metabolism. Other organs include lungs, kidney, and adrenals. Drug metabolites need to be water soluble to be eliminated by the kidney, which means the soluble drugs need especially extensive modification, right? They can be made more water soluble by metabolic processes such as conjugation, which means attachment to something that's water soluble, or other metabolic processes that render the metabolite more water soluble. Now, we're going to find out that one of the big enzyme systems that does this, okay, is something called cytochrome P450. Let's back up. Okay. Okay. So it turns lipid soluble compounds into water soluble. Very important, right? So let's look at biotransformation.
Drug metabolism is the chemical conversion of drugs into water-soluble compounds that can be excreted by the body. Drug metabolism mainly takes place in the liver, while excretion mainly takes place in the kidneys. Following drug administration, drugs must pass through tightly packed cells, crossing cell membranes to reach their sites of action. Usually drugs are lipophilic or fat-soluble compounds, and cell membranes are composed of phospholipids, so drugs are able to cross them. However, for excretion by the kidneys, it's necessary to convert drugs to water-soluble or hydrophilic compounds. Drugs are usually administered orally or parenterally. Parenteral drugs bypass the digestive tract. Parenteral routes include injection, transdermal patches, lotions, inhalants, and suppositories. If injected, the drugs reach general circulation quickly and have an immediate effect. If taken orally, drugs must pass through the cells of the gastrointestinal tract. Drugs cross through cells of the GI tract and travel to the liver via the hepatic portal vein. The liver has a chance to metabolize some of the drug before it goes into general circulation. This is called the first pass effect. In the liver, drugs enter hepatic cells, where a series of enzymes in smooth endoplasmic reticulum metabolize them. Drugs move through the phospholipid membrane of endoplasmic reticulum. Hepatic microsomal enzymes, such as P450, convert drugs from lipophilic to hydrophilic compounds. Repeated use of certain drugs increases the amount of metabolic enzymes and increases drug metabolism. This is called enzyme induction. Conversely, certain drugs compete to bind to metabolic enzymes, thereby decreasing drug metabolism. This is called enzyme inhibition. Once metabolized, these hydrophilic metabolites leave the cell ready for excretion by the kidney. A drug's duration and intensity of effect are largely determined by metabolic rate. Increased metabolic rate will decrease drug duration and intensity by facilitating excretion. Decreased metabolic rate increases drug duration and intensity. A few of the factors affecting metabolic rate are: the first pass effect, liver disease such as cirrhosis. Neonates and the elderly have decreased liver function. Compromised blood flow to the liver will lower metabolic rate. Variation in amount and type of hepatic enzymes. Poor diet and nutrition can affect normal liver function. And higher circulating drug levels due to dosage or patient's weight take longer to metabolize.
Phase one reactions convert drugs into more ionized molecules by the introduction of already existing ionized components of the compounds, while phase two reactions are synthetic reactions in which new compounds are introduced to chemically altered drugs. Okay. So you might say, well, like what? All right. Examples of phase one biotransformation. So this is the liver doing this. All right. Cytochrome P450 dependent. Okay. We talked about this earlier, right? The job of cytochrome P450 is to turn something lipid soluble to something water soluble. All right. So examples, right? Hydroxylation. What would that be? Adding hydroxyl groups to the compound. You can see this in drugs like amphetamines and barbiturates. Dealkylation, all right, which means to remove methyl groups or ethyl groups, for instance, right, from the compound to make them less hydrophobic. Okay, examples include caffeine and morphine. O-dealkylation, all right, which means to remove an alkyl group from a nitrogen, right? I'm sorry, an oxygen. Examples include codeine. So you might ask, what? Show me. Okay, so let's show you. All right. All right. Hydroxylation. All right. So let's say that you have a compound. I don't care what it is. It could be something as simple as this is butane. Not that you'd ever take butane, right? But if we hydroxylated it, what would we do? We would add an OH group to the butane to make it more water soluble. Okay. N-dealkylation. Okay, let's say that you have a compound that has a nitrogen in it, like let's say it's a with a ring. Okay, these are all organic compounds. Okay, nitrogen-containing compounds, and then you have maybe a methyl group hanging off of there. Right? N-dealkylation would take it from that to just this. Okay, rendering it more water soluble. Okay, O-dealkylation. Right, so you would have an ester of some kind, right? And that would be a methyl group there. Okay. And that would be a methyl group there. And in the O-dealkylation, you would turn this into, this is ethyl alcohol, right? Strip this off. You just take it out. Okay. S-oxidation, right? What happens here is that you turn a sulfhydryl group into a sulfate group. Okay. So the idea there is sulfates are more water soluble than sulfigrals, right? Other oxidations that are P450 independent, amine oxidation, such as an adrenaline, okay? Dehydrogenation, which you see in ethyl alcohol chlorohydrate. So an example of dehydrogenation, right? Here's ethyl alcohol, okay? Right? We dehydrogenate it, right? We remove hydrogens, right? We can turn this into uh, something like that, right? The double bond in it, okay? Hydrolysis, meaning use a water molecule to split something, okay? Lidocaine and procainamide are examples. Amide and ester oxidation, okay? Aspirin and procaine. An amide is something that looks like this, okay? Double bond and a nitrogen, okay? And then another bond there and then a free. Okay. So with an amide, all right, when you're oxidizing it, what you're doing is you're going to attach perhaps a keto group to it, right? And so you might turn this into something like that, right? And then reduction, things like chloropheticol and naloxone. Okay. Now I know a lot of you probably haven't had organic chemistry, but bottom line, with the idea behind oxidation reactions and most of these other reactions is to remove lipid soluble groups, which would be basically hydrocarbons, all right, and replace them with electronegative atoms like oxygen or sulfur or nitrogen, okay, or to add hydroxyl groups or water, all right, just to make them more water soluble. Okay. Some phase 2 biotransformations, okay. Acetylation, right, which just happens in mescaline and sulfonamide. Conjugation, which happens with glutathione, glycine, and sulfate in the body, right? And examples of drugs that are targets of that: bromobenzene, uh, benzoic acid, salicylate, okay, and so on, okay. And glucuronidation, which happens with digoxin and morphine, and methylation with dopamine histamine, okay. Clearance, right, happens primarily through the kidneys by glomerular filtration, tubular absorption, and secretion, right? Some drugs are metabolized in the liver and excreted through the bile and the feces as well, right? In the lungs, in addition to being a route of administration, it's also a potential path of elimination for drug metabolites in expired air, okay? Other paths of clearance include sweat, saliva, tears, and the production of breast milk, which can be a hazard for the newborn, okay? So let's look at clearance.
The body filters drugs from the bloodstream and eliminates them in a multi-step process called medication excretion. The kidneys are the major route for drug elimination. Most drugs exit the body either unchanged or as drug metabolites in urine. Generally, health professionals refer to the ability of the kidneys to filter blood as renal function. Nephrons, the functional and anatomical units of the kidney, filter blood, regulate fluid volume and pH, and control levels of electrolytes in the body. Each nephron contains a renal corpuscle and renal tubule. The renal corpuscle includes the Bowman capsule and glomerulus, and the renal tubule is composed of the proximal tubule, loop of Henle, distal tubule, and collecting duct. Each component plays a role in renal drug excretion. a four-step process that allows the kidneys to filter and eliminate drugs from the body. These steps are glomerular filtration, passive tubular reabsorption, active tubular secretion, and excretion. Blood flows into the glomerulus via a blood vessel larger in diameter than the vessel draining blood from the glomerulus. This difference in diameter creates the high blood pressure necessary to filter wastes from the blood. The glomerulus functions as a molecular sieve. Waste materials and water pass through the sieve, while most normal proteins and cells are kept in the bloodstream. Glomerular filtration removes low molecular weight drugs from the bloodstream. The process of passive reabsorption of water, solutes, and ions begins in the proximal tubule, continues in the Henle loop, and ends in the distal and collecting ducts. Water-soluble drugs stay in the tubule, while unionized and lipid-soluble drugs are primarily reabsorbed across renal tubules. After reabsorption, lipid-soluble drugs travel through the bloodstream to the liver, where certain liver enzymes, such as the cytochrome P450 enzyme complex, metabolize them into more water-soluble forms. Here we show an example of this process through the metabolism of pentobarbital. Some drugs are not filtered from the blood via the glomerulus. Instead, special anionic and cationic pumps in the walls of the renal tubule actively transport the drugs from the blood into the tubules and collecting duct. Urine from the collecting ducts travels through the ureters, where it is collected and stored in the urinary bladder until elimination from the body. Although the kidneys are the major route for drug elimination, medication excretion can also occur in lactating women through their breast milk, exhalation through the lungs, release into bile, and elimination through saliva and sweat.
We have to consider, right, the response of the body to the administration of the drug. Okay. They're split into dose effects, time effects, variability, and toxicity. Okay. Dose effect is the dose of the drug, is the amount given at a single time. Okay. The dosage is the total amount given over a period of time. Recall that all drugs are potentially poisonous depending on the dose given. The effect of a drug depends on the dose, and it's essential to determine what a given dose will do to a patient. As an example, a dose of a drug given to a patient that's a 5 milligram tablet, if it's administered for 5 days, equals a dosage of 25 milligrams. 5 times 5 is 25, right? Dose and dosage are not used interchangeably, okay? The margin of safety or therapeutic index is the amount of drug that's going to produce the therapeutic effect versus the amount of drug that can produce a harmful effect, right? And so what you want is a large therapeutic index, right? For a drug to be safe, the highest dose necessary to produce a therapeutic effect has to be lower than the lowest dose required to produce death. That's the measurement of death is called the LD50, lethal dose 50%. Okay? So that's the amount of a drug that would kill 50% of the participants. Okay. Individuals may vary considerably in their responsiveness to a drug. Biological variation among patients leads to pharmacological variation in the dose response of patients. Overcoming pharmacological variation requires quantitation to minimize errors in prediction. Okay. So a high therapeutic index is safe, a low one is going to be unsafe, right? So you can see here in this figure an example. Okay. A high therapeutic index indicates that the drug is relatively safe, whereas a low therapeutic index indicates that the drug is unsafe, right? Drug A has a high therapeutic index and is safe. Okay. Drug B shows overlap with the therapeutic effect curve and the lethal effect curve, and therefore it's unsafe. Okay. LD50 means lethal dose 50. ED50 means effective dose 50. Okay. So you need a split between those two in order to determine your choice of drug, right? Now, sometimes you can't do that, right? Sometimes you don't get the opportunity for a high therapeutic index. And so then you have to factor in things like the condition of the patient, the age of the patient, um, and drug interactions that could be lethal. Okay. And that you get through the patient history. The time effect, right? Dose response includes magnitude of response after a single dose, excluding other factors that affect the concentration at the site of action. An example is time, right? A selected time is chosen and measurements are taken to determine minimum, maximum, or any other chosen level of response at that time, right? Time response measures include time of drug administration, onset of time response, when the drug stops working, the peak effect, the duration of action, the latency of the effect, and the threshold level. Okay, the peak effect occurs when receptors are maximally activated. This effect is determined by the rate of movement of the drug to the site of action and removal of the drug from the site of action. It should be noted that with high concentrations of drug, the rates of elimination are high. Right? Latency is regulated primarily by the time a drug takes to get to the site of action. Okay, so that includes the rate of absorption, distribution, and focusing after it arrives at the site of action in the target. This may also include conversion time from inactive to active forms of the drug. The time response curve indicates the time of drug administration, the onset of the time response, which is the threshold, the peak effect, the duration of action, and the cessation of the effect. In addition, it indicates the toxic concentration of a drug and the therapeutic range and the minimal effective concentration of the drug. Okay, so you can see all of those in this particular diagram, right? So there's your toxic concentration, right? And there is your therapeutic range, and there's your minimum effective concentration, right? The goal would always be to have the minimum effective concentration be way below the toxic concentration, okay? And that gives you a wide range for therapeutic action. Factors that influence preparation for excretion elimination are subject to variability. The first pass effect is the biotransformation of a drug subsequent to oral administration and before entering general administration. It's the combined action of intestinal and hepatic drug metabolizing enzymes on the drug's bioavailability, which is the extent to which a drug is absorbed and is available to its site of action, right? So remember, right, when you talk about enteral, especially, right, the first thing we do after we're absorbed across the line in the gut is we head right to the liver, right? And the liver deals with it in some way and then passes it back into the circulation. Same way it does with your food, okay? The chemical properties of a drug have an impact on this. Its molecular weight, its charge, and its solubility. Is it primarily lipid soluble? Is it primarily water soluble? Okay. Toxic effects typically occur due to depletion of enzymes needed for detoxing the drug. Liver and kidney disease result in an inability to metabolize or excrete the drugs, respectively. Starvation usually results in a decreased ability to conjugate with glycine because of depletion of amino acids in general. In age, right, neonates fail to metabolize drugs the same way as adults or the elderly do. And then genetics, right, some patients are unable to metabolize succinylcholine, as an example, resulting in succinylcholine apnea during the recovery after surgery, right? Then, of course, there's species variability, right? Gender effects, all right? All of those have to be considered. Toxicity can be grouped as acute, subacute, or chronic, right? Toxic and or undesired drug effects are somewhat interchangeable terms. Toxic effect is an effect that's harmful to a biological system, whereas an adverse effect can be harmful in some but not all systems. Okay? Mild reactions include drowsiness, nausea, itching, and rash, whereas more severe adverse effects include respiratory depression, neutropenia, hepatocellular injury, anaphylaxis, and hemorrhaging, all of which can kill you. Okay. An acute effect occurs within minutes or hours after exposure. A subacute occurs after repeated exposure, and chronic occurs over months to years, during which time the rate of exposure exceeds the rate of elimination. Okay. Determination of drug safety or toxicity is based on comparisons with other drugs or poisons to measure relative safety levels. As an example, penicillin is considered safe compared with malathion, as well as compared with neomycin. Okay. Non-specific treatment of suspected poisoning always includes support of respiration and circulation, in addition to removing the patient from exposure to the poison, identifying the poison, giving an antidote, instituting poison elimination procedures, and instituting supportive measures for the patient. Okay? The study of poisons is called toxicology, right? And it includes physiochemical properties of the toxin, routes and rates of administration, rates of absorption, biotransformation and excretion, and adverse effects of the chemicals in the environment. Okay? Development of new drugs is an extensive and expensive process involving research and development, review of new drug applications, and post-marketing monitoring, which results in the acceptance or the denial of the drug by the Federal Drug Administration, the FDA. Okay? Schedules of controlled substances include 1, 2, 3, 4, and 5. Let's take a look at drug scheduling.
Welcome back to Alpha Nurse Guide. My name is Sandro. This is Pharmacology for Nursing Lesson 1.3, Drug Schedules. If you want to skip for this video, you can go to alphanurseguide.com. You can follow me on Facebook, Twitter, Instagram, and TikTok to get any updates. And you can follow this channel on odyssey.com. All links will be in the description. Without a way, let's get started.
Controlled Substances Act. The Comprehensive Drug Abuse Prevention and Control Act, which is commonly referred to as the Controlled Substances Act, was passed by Congress in 1970. This statute repealed almost 50 other laws written between 1914 and 1970 that related to the control of drugs. The new composite law was designed to improve the administration and regulation of the manufacturing, distribution, and dispensing of drugs that require control by the government because of their high incidence of abuse. The basic structure of the Controlled Substances Act consists of 5 classifications or schedules of controlled substances. The degree of control, the conditions of record keeping, the particular order forms required, and other regulations depend on these classifications. Schedule 1 drugs. Very high potential for abuse. Not currently accepted for medical use in the United States. Lack of accepted safety ways for use under medical supervision. Examples: lysergic acid diethylamide, LSD, peyote, hashish. Schedule 2 drugs. High potential for abuse. Currently accepted for medical use in the United States. Abuse potential that may lead to severe psychological or physical dependence. Requires new prescription, no refills. Examples: amphetamines, morphine, hydrocodone/acetaminophen, Vicodin. Methadone, oxycodone/aspirin, Percodan. Schedule 3 drugs. High potential for abuse, but less so than drugs in Schedules 1 and 2. Currently accepted for medical use in the United States. Abuse potential that may lead to moderate or low physical dependence or high psychological dependence. Prescription outdates in 6 months, no more than 5 refills in those 6 months. Examples: aspirin/codeine, Empirin with codeine. Aspirin/butalbital/caffeine, Fiorinol. Acetaminophen/codeine, Tylenol with codeine. Schedule 4 drugs. Low potential for abuse compared with drugs in Schedule 3. Currently accepted for medical use in the United States. Abuse potential that may lead to limited physical or psychological dependence compared with drugs in Schedule 3. Prescription outdates in 6 months, no more than 5 refills in those 6 months. Examples: phenobarbital, chlordiazepoxide, diazepam, flurazepam, temazepam. Schedule 5 drugs. Low potential for abuse compared with drugs in Schedule 4. Currently accepted for medical use in the United States. Abuse potential of limited physical or psychological dependence liability compared with drugs in Schedule 4. Because abuse potential is low, a prescription may not be required. Prescription outdates in 6 months, no more than 5 refills in that 6 months. Example: atropine/diphenoxylate, Lomodal, Verticin AC. Drug Schedule Rules. Drugs that are listed in Schedule 1 are not available for other than highly controlled research purposes. Drugs in Schedule 2 are available by prescription, only in limited quantities, usually no more than a 30-day supply. The prescription cannot be refilled, a new prescription must be issued for continued use. Drugs categorized as Schedule 3, 4, or 5 may be ordered by prescription with a maximum supply of 30 days of medicine. The prescription may be refilled up to 5 times, but outdates at 6 months, at which time a new prescription is required if the medicine is to be continued. Prescription medicines that are not classified as controlled substances may be refilled for up to 1 year, if approved by the prescriber. Most state laws mandate that a prescription outdates in 1 year. Which schedule does diazepam fall in? A. Schedule 1. B. Schedule 2. C. Schedule 3. D. Schedule 4. E. Schedule 5. The correct answer is D. Schedule 4. Rationale: examples of schedule for drugs are phenobarbital, chlordiazepoxide, diazepam, flurazepam, temazepam. 2. Which schedule does acetaminophen/codeine fall in? A. Schedule 1. B. Schedule 2. C. Schedule 3. D. Schedule 4. E. Schedule 5. The correct answer is C. Schedule 3. Rationale: examples of Schedule 3 drugs are aspirin/codeine, empyrin with codeine, aspirin/butalbital/caffeine, Fiorinol, acetaminophen/codeine, Tylenol with codeine. 3. Which schedule does methadone fall in? A. Schedule 1. B. Schedule 2. C. Schedule 3. D. Schedule 4. E. Schedule 5. The correct answer is B. Schedule 2. Rationale: examples of Schedule 2 drugs are amphetamines, morphine, hydrocodone/acetaminophen, Vicodin, hydrocodone/acetaminophen, Lortab, hydrocodone/acetaminophen, Norco, methadone, oxycodone/aspirin, Percodan, methylphenidate, Ritalin, amphetamine/dextroamphetamine, Adderall. 4. Which schedule does hashish fall in? A. Schedule 1. B. Schedule 2. C. Schedule 3. D. Schedule 4. E. Schedule 5. The correct answer is A. Schedule 1. Rationale: examples of Schedule 1 drugs are lysergic acid diethylamide, LSD, peyote, hashish. 5. The nurse is administering Lomotil, a Schedule 5 drug. Which statement is true about this drug's classification? A. Abuse potential for this drug is low. B. Psychological dependency is likely. C. There is a high potential for abuse. D. This drug is not a controlled substance. The correct answer is A. Abuse potential for this drug is low. Rationale: Lomotil, a Schedule 5 drug, has an abuse potential of limited physical or psychological dependence liability compared with drugs in Schedule 4. Because abuse potential is low with a Schedule 5 drug, a prescription may not be required. Psychological dependency is not likely with a Schedule 5 drug. Schedule 5 drugs are classified as controlled substances.
Alright, that's all I have for this video. Let me know what you got on the quiz. If you have any question, feel free to let me know in the comment section. If not, I'll see you in the next video. Thanks for watching.